Hi, my name is Jennifer Chu. I'm a physical therapist based in Vancouver, BC, and today we're going to be talking about shockwave therapy versus laser therapy on lower extremity pathologies. If you've never heard of shockwave therapy and laser therapy before, they are two modalities that can be used quite effectively in the physical therapy clinical setting when using the correct frequencies and dosages and in the right patient populations. They can be modalities that offer low risk and high reward results in both upper and lower extremity soft tissue pathologies. But for the purposes of today's seminar, we will be exclusively looking at the results that shockwave and laser therapy can have on lower extremity pathologies. So after today's presentation, you should have a good understanding of the mechanism of action behind shockwave and laser therapy, as well as their effects on lower extremity pathologies. We're also going to compare and contrast the clinical efficacy of these two treatment modalities for some common lower extremity conditions that we see clinically in physical therapy practice. This information will then help us to identify the appropriate patient populations to use these two modalities on to get us the best results based on today's most current literature. First, we will go over what shockwave therapy is. Shockwave therapy can be abbreviated with the letters ESWT, which stands for Extracorporeal Shockwave Therapy. Shockwave therapy was first introduced into clinical practice back in 1982, and ever since then, it has been a beneficial inclusion to the non-invasive treatment options available for numerous orthopedic pathologies. Even though this non-invasive treatment option has been around for over 40 years, it really isn't until in the last decade or so that it has become more widely used in physical therapy clinical settings. That is why a lot of clients who come to see me often have not heard of shockwave therapy before, even though they have done physical therapy in the past. In earlier in vitro and animal studies, shockwave therapy was seen to promote cellular reparative effects by breaking down scar tissue, increasing blood supply, and stimulating the release of growth factors. And it was through these earlier studies that more research has gone into developing shockwave therapy as the shockwave that we use in physical therapy today for different types of lower extremity pathologies. After reviewing randomized controlled trials, systematic reviews, and meta-analyses, the literature all seem to agree that shockwave therapy uses sonic pulses to stimulate the wound healing cascade. This stimulation then allows chronic damage to become acute damage in order to initiate the normal wound healing process. Therefore, shockwave therapy is viewed as a pro-inflammatory modality. While it is pro-inflammatory, these sonic pulses can also help to inhibit pain receptors in the targeted area, and the microinflammation that these pulses trigger stimulate a process called mechanotransduction. Mechanotransduction is the process by which these sonic pulses place mechanical loads on the cellular cytoskeleton, and this in turn induces signals for cellular repair through the release of growth factors and increases the formation of new vessels and oxygenation to speed up tissue healing. These sonic pulses also stimulate the body to remove the damaged matrix components associated with any pathological substances and tissues in the body. So as you can see, there are lots of cellular repair signals that are initiated through these sonic pulses when it is effectively used in targeted areas. For those of you who have heard of shockwave therapy, you might know that there are two types of shockwaves. One is called radio shockwave and the other is called focal shockwave. Radio shockwave is what we use in physical therapy practice. And as you can see in this image here, radio shockwave produces a diverging pressure field, while focused shockwave applies a converging pressure field. In physical therapy practice, we use radio shockwave, and all the research that I'm presenting to you today is all based on radio shockwave. This is because focused shockwave is typically less accessible for patients because they are usually only available in physicians' and specialists' offices and not usually in physical therapy settings. There was a study done by Yusuf and colleagues that concluded that there wasn't a significant difference between radio and focused shockwaves in their efficacy in treating pathologies, even though focused shockwaves would be able to penetrate into deeper tissues than radio shockwaves can. Focused shockwaves also tend to be more painful as it is penetrating into deeper tissues. With the dosage of recommendations with radio shockwave, it is about 2,000 to 3,000 pulses with a frequency of 10 to 15 Hz, with energy increasing from 1.4 to 3 bars for 3 sessions once a week. And of course, this is just a guideline. In my practice, I do typically see patients for longer lengths of time, usually anywhere from 4 to 12 sessions once a week, because this length of time allows me to progressively build them an exercise program and allows me to monitor my patient's progress and exercise technique to be used in conjunction with shockwave therapy. I personally don't use focused shockwave therapy, so I can't speak much behind these parameters, but they are on the slide if you're interested. So now we will move on to laser therapy. Laser therapy can also be abbreviated as LLLT, which stands for low-level light therapy. Laser therapy has been around a little longer than shockwave therapy, as it was first discovered in the literature as early as 1968 to have influence on living tissue. Laser therapy uses the processes of photobiomodulation and photobiostimulation to trigger different biochemical reactions in the body. It can promote cell proliferation and regenerate tissue with its light energy. And although laser therapy can have a warming effect, it is simply the light energy or the photobiostimulation part of laser therapy with its red and near-infrared light that stimulates tissue healing and helps to reduce pain and inflammation in cells and in the body. As a biostimulant, laser therapy accelerates the self-repair activity of living tissue. It does that by increasing the permeability of the cell membrane and can also accelerate the fibroblast activity by increasing cell metabolism through increasing ATP production to accelerate the body's natural healing response. Furthermore, it can have an analgesic effect on neurotransmitters like serotonin to lessen the body's pain response to the specific pathology. The dosage of laser therapy is a lot more standardized than shockwave therapy and should be much more strictly followed because the current literature does suggest a dose-response relationship between treatment protocols and the success of the treatment. The correlation with the dose-response relationship is so strong that the World Association for Laser Therapy, also known as the WALT group, has published disease-specific dosage recommendations for laser therapy. The literature also suggests that the effect of laser therapy is partly cumulative. So on the next slide, we will discover that laser therapy needs to be delivered a lot more frequently than shockwave therapy for it to be effective, especially for more acute conditions. So these are the WALT guidelines. I have listed the recommendation guidelines for plantar fasciitis and Achilles tendon since we're talking about lower extremity pathologies today. The main takeaway from this slide is that daily treatment for 2 weeks or treatment every other day for 3 to 4 weeks when using any type of laser therapy is recommended and strongly advised. This statement was written in all of the treatment dosage recommendation documents they have published on their website. Now I want to remind us of the dosage recommendations that were established in the literature for shockwave therapy, which was once a week for 3 to 4 weeks. With laser therapy, it is daily or every other day for 3 to 4 weeks. Therefore, simply from the dosage perspective, it seems to be much more feasible, both for patients' time and costs incurred, for patients to be getting shockwave therapy once a week versus laser therapy daily for the same length of time. So let's talk about the indications for these two modalities now. Shockwave therapy seems to be effective for conditions including plantar fasciitis, tendinopathies, Morton's neuroma, delayed bone healing, and calcaneal spurs. While laser therapy seems to be effective for plantar fasciitis, tendinopathies, muscle strains, and ligament sprains. So there are definitely some similarities and differences when looking at these two modalities on treating lower extremity pathologies. In my experience, shockwave therapy is usually used in chronic cases since we are triggering that pro-inflammatory response, and laser therapy, since it can be both anti-inflammatory and pro-inflammatory, can be used in both chronic and acute cases. With contraindications, most of these are quite obvious. For shockwave therapy and for laser therapy, we would not use it for any treatment areas where there is any local malignancy. One thing to note is that shockwave therapy is deemed to still be safe when cancer is a concomitant disease. Other contraindications include pregnant women. We don't want to be using either modalities in the abdomen or lower back in women who are pregnant. We also would never use shockwave directly on the epiphyseal growth plates for kids who have not gone through puberty and have finished with their growth spurts, as the shockwaves could have an effect on their growth. With laser therapy, we don't want to be using it on any hemorrhagic conditions, any regions with active DVTs, and tissues infected with bacteria or viruses. Lastly, we don't want to use laser therapy directly on the eyes, reproductive organs, and on the thyroid gland. So these are the contraindications that are published. Of course, we should always still evaluate each patient on a case-by-case scenario before we proceed with using either of these modalities. So now we're onto the literature review portion where we can compare and contrast the use of shockwave versus laser therapy on lower extremity pathologies based on the latest evidence we have on the topic. The first study that we'll go over is by Samak and colleagues. This study compared the efficacy of shockwave and laser therapy in terms of fascial thickness, heel pain, and foot functions in patients with plantar fasciitis, and they followed similar dosage protocols as we have previously discussed when administering both shockwave and laser therapy. The patients in Group 1 received just 3 sessions of shockwave for 3 weeks, and the patients in Group 2 received 12 sessions of laser 3 times a week for 4 weeks. This slide is a bit wordy, but basically they found statistically significant results based on their chosen outcome measures when comparing plantar fascial thickness, foot function index scores, and visual analog pain scale scores pre and post treatment for both shockwave and laser therapy groups. Again, this is available on the slide if you would like to take a more detailed look at their findings. So in conclusion, they reported that both shockwave and laser therapy seem to be effective and not superior to one another on pain, foot function, and fascial thickness in the treatment of plantar fasciitis. This conclusion is great for us in the physical therapy setting because the evidence is in favor of using these non-invasive treatment options in making a positive outcome on our patients' rehabilitation process. As a physical therapist, when I read the study, the main thing that did jump at me, as I have previously spoken to you about, is the dosages required for clinical efficacy. They administered shockwave therapy a total of 3 times once a week and laser therapy a total of 12 times every other day to get similar results. Now let's move on to the second study by Ulusoy and colleagues where they compared laser, shockwave, as well as ultrasound therapy for the treatment of plantar fasciitis. Group 1 received 15 sessions of laser, Group 2 received 15 sessions of ultrasound, and Group 3 received 3 sessions of shockwave. And this study as well followed the dosage recommendations we have spoken about earlier in our presentation. So what did they find? Firstly, the plantar fascial thickness did decrease significantly on MRI in all 3 groups. The other outcome measures they used were mean visual analog scores, American Orthopedic Foot and Ankle Society scores, and heel tenderness index scores. These outcome measures are all valid and reliable outcome measures that are commonly used in the studies that I have reviewed in my literature search for this presentation. So this study was able to substantiate the correlation between fascial thickness reduction and decreased first step in the morning pain. Here you can see the treatment success rates for laser, shockwave, and ultrasound therapy respectively. Based on this information, Ulusoy and colleagues concluded that both laser and shockwave therapy proved to be significantly superior to ultrasound therapy, but there was no statistically significant difference between the laser and shockwave therapy groups for the treatment of chronic plantar fasciitis to help with pain management and improve functional outcomes 1 month post-treatment. Seeing these percentages, we do have to keep in mind that even though all of these patients have plantar fasciitis, there were still about 20 to 30% of patients who did not respond to these non-invasive treatment options. Clinically, I typically treat clients for longer lengths of time as I know that outcomes are also clinically linked to my exercise prescription, training regimens, and education and activity strategies than what the study here has done. So I do find that my personal success rate for treating clients with plantar fasciitis with shockwave therapy to be of a higher percentage. Another thing that is important to note here is that in my clinical practice as a physical therapist, I don't just use shockwave or laser therapy as a standalone treatment. In the study, the researchers' inclusion criteria were individuals who were unresponsive for 6 weeks of first-tier conservative treatment like home exercises and standard insoles. They also outlined that the exercise program given to these study participants included plantar fascia stretching, calf muscle stretching, Achilles tendon stretching, and intrinsic foot muscle strengthening. In my clinical practice, a lot of the time, this home exercise program that was outlined in the study may be a bit too generic and may not be enough to make an effective change on our patient's overall function. With my specialty in treating lower extremity pathologies within the physical therapy space, I have found that obviously each case of plantar fasciitis is different since every body is different. Whether that is patients with different foot structures, either high arch, neutral, or low arch, hyper or hypomobility with their ankles, knees, and hips, and also whether this patient in front of me has any other body parts that might also be in pain or that they have had surgeries or have hurt in the past, resulting in compensatory movement patterns and compensations in their body structure and alignment. So focusing on strengthening and stretching the ankle and foot complex alone typically doesn't make enough of an effective change on altering the patient's overall function to offload the plantar fascia in order to prevent further damage and to promote healing. A lot of times we might also need to address hip and core mobility and strength as well as teaching optimal movement patterns like not scrunching your toes when you're walking or when balancing on one foot. You'll be surprised to find out how many people don't realize these little things they have been doing all their lives without realizing it, and have over time lost the function of their feet and thereby placing more loads onto the plantar fascia, leading to plantar fasciitis. Now let's move on to our third study. This third study is by Yusuf and colleagues, and it is a systematic review and meta-analysis of using shockwave therapy for foot and ankle disorders. As I have mentioned previously, most of the evidence on shockwave therapy has been done on plantar fasciitis, and that is then followed by tendinopathies, calcaneal spurs, and Morton's neuroma, respectively. As you can see here, more evidence should be done before we can establish the scientific backing that shockwave is effective for these two latter lower extremity pathologies. But of the limited evidence that is available, all of these lower extremity pathologies seem to have some evidence to support the clinical efficacy to help patients improve their symptoms. Now, this is our final study of the presentation today. This study is by Naderstad and colleagues. It is another systematic review and meta-analysis of randomized controlled trials to compare the efficacy of laser therapy with patients with lower extremity tendinopathies or plantar fasciitis. Similar to our previous systematic review and meta-analysis by Yusuf and colleagues, there was a lot of evidence on laser therapy used for plantar fasciitis, followed by Achilles tendinopathy and then patellar tendinopathy. So in the randomized controlled trials that were analyzed in the systematic review and meta-analysis, overall pain and disability were both significantly reduced using laser therapy over the placebo control. However, what was important to note was that there was a significant reduction in pain at completed therapy only with recommended laser doses, and non-recommended laser doses had no significant effect. So in conclusion, this systematic review and meta-analysis helped us to further substantiate the importance of the dose-response relationship when using laser therapy in order for us to have a positive outcome. So in conclusion, after reviewing the current literature, there is strong evidence to suggest that both shockwave and laser therapy are effective modalities that should be trialed before more invasive measures such as injections are considered, due to them being less invasive and less painful in nature. Overall, the evidence does suggest that both modalities can help to promote healing and decrease pain. With a reduction in pain, we are then able to improve our patients' quality of life through education and implementing good exercise habits through physical therapy. Just to reiterate one more time, in terms of patient selection for most positive and successful outcomes, plantar fasciitis does seem to be the pathology with the most scientific backing, followed by tendinopathies like Achilles tendinopathy. I have personally also had good clinical success with treating peroneal tendinopathies and tibialis posterior tendinopathies using shockwave therapy. Lastly, just to put it all together and summarize my presentation today, both shockwave therapy and laser therapy can deliver quite impressive results, with them both being low-risk modalities. In physical therapy practice, what I have found is that using a modality in conjunction with educating my patients and putting together an exercise program for them, we can often improve patient buy-in to the physical therapy treatment plan when we tell them the scientific evidence on trialing shockwave therapy in conjunction with their exercises. A lot of times, patients feel like they are in better hands when they get treatment together with their exercise program. We know that in physical therapy practice, exercise is the part where we can help our patients improve their overall function and thereby their quality of life the most. But that initial patient buy-in can sometimes be tricky with patients who have perhaps lived most of their lives as sedentary individuals. Personally, I have found it to be very beneficial having shockwave therapy as an adjunct in my physical therapy practice, and I tend to use this modality in conjunction with education with my patients, exercise programming, and together also with some manual therapy and dry needling as needed. If this presentation has piqued your interest in referring for these modalities, please know that not all practices would have these modalities, so I would encourage you to have an understanding of some practices that do and that you would feel comfortable referring to. Thank you so much for your time and listening to me speak on this topic. And now I welcome any questions.